Okay, we've got 18, so I think that's a good quorum. So let's get started. So this is our final session. And as I said last week, we have reserved this session to tie up any loose ends. And there weren't a whole lot this time, and that's normal. And if you do come up with questions or suggestions, the whole team is very ready to receive them. I know you get requests for feedback on every single session, as well as the overall evaluation, and it does help us refine things. In fact, this whole series on health equity and cardiovascular risk emerged because of feedback from you over the last couple of years or so. Let me just advance these slides. Again, no PHI to be discussed, of course. Assistance and contact information is unchanged. This is the general information about cardio. I will facilitate as usual. We have a couple of cases to discuss from Alicia and Sue Hall, but we have got 3 potential discussants. We'll see. We do have more time than usual because there's not going to be a formal lecture. So we'll involve Doctors Werner, Dungan, and Clemens. These are our usual disclosure statements. So I think Austin, I think both of these are your questions that had come up. And as we go through the case studies, I wanted to share something else as well, based on my experience. But the first question is on diabetes control. Should we briefly assess perioperative management of the newer diabetes medicines? And I'm glad Austin asked this, because I get asked by surgeons, what should we do with their GLP-1? It hasn't been a big issue. I mean, you don't take PO meds the day of the surgery. If it's a GLP-1, most of them are now weekly. So they're not gonna, you just take it as usual, is what I've said. But I really like to hear Kathleen's thoughts on it, because that's just my own made up strategy. So Kathleen, do you want to start us off?
Sure. Yeah, there has been a lot of discussion on this in the last year or so, because the anesthesiology society, I forget the name of the ambulatory surgery and anesthesiology society, actually added specific recommendations to their latest set of guidelines on the use of GLP-1 receptor agonists prior to anesthesia. And their concern is that there have been some case reports, mostly, describing concerns about aspiration and delayed gastric emptying. And this can have really profound impact on perioperative outcomes when it's come time for recovery. And so they've actually recommended stopping the GLP-1 if it's a weekly GLP-1 at least a week before, and daily GLP-1s a few days before. And so there's been a lot of heated discussion on this matter, and people on both sides, because there's very little high quality evidence in one way or the other. And the GLP-1 receptor agonist's effect on gastric emptying, at least for the continuously activating agonists, which are the vast majority of agents used today, the effect on gastric emptying is really worn off after several weeks of use. So there's no consideration for the duration of impact. And in addition, gastroparesis can be, of course, observed even in people who aren't using these agents. And the bottom line, it's such a concern for the anesthesiology community that they've really kind of held firm for the most part. And I think most institutions are implementing this. And this is beside the fact that the half-life is so long for these agents that even if you hold it for a week, you're really not going to get below therapeutic levels. So there's that. There's been some discussion, maybe some institutions, of maybe holding them longer for people who are using them for weight loss, for example, for whom glycemic control won't be an issue, and so forth, but thus far not clear. For the SGLT2 inhibitors, I think this is a bit more clear because there have been many cases of perioperative metabolic acidosis and euglycemic DKA, particularly in insulin requiring patients. So in general, the recommendations is to stop them about four days or so before any planned surgeries.
Okay, thank you, Kathleen. I guess the bottom line is, let's follow their recommendations, but it doesn't seem like, it just seems speculative to some extent, but probably prudent. And yeah, it's hard, Kathleen, to know. I mean, it's delayed gastric emptying, but there's still going to be NPO for the most part. So I'm not sure what they would be aspirating with these GLP-1s anyway, but interesting recommendation. Okay. Any other thoughts about that before we go on? Okay, let's go to our next question. Also from, yeah, go ahead. Paul?
Yeah, yes, sir. Thank you. If I may briefly, one concern that we see in Southeast is clients are taking other medications that can contribute to gastroparesis as well. So we have found, we have discussed being careful adding the GLP-1s when somebody's taking an antipsychotic medication or other medication that can cause gastroparesis. And it kind of falls along the same thought process. To Kathleen's point, half-life of Trulicity is about 5 days. So there may or may not be some effect after you've skipped the dose for a week. But I just wanted to mention that there has been some discussion about concern about additive gastroparesis, because when you're adding the GLP-1 to something else, that can cause it. That may be a concern. That's just been a discussion we've had.
Okay. Thank you. Appreciate that. And this question is for Danette about the perimenopausal presentation. And Austin, do you want to clarify? I read your question last night.
Yeah.
Yeah.
No, they were just simple. I mean, honestly, all of the lectures are so good, including especially Kathleen's diabetes management one, and then this hormone replacement therapy I really, really liked. To Kathleen's, that's exactly, I was just like, man, we're getting these memos all the time from every surgery center as though anesthesiologists just immediately found out that GLP-1s have some predisposition to cause some gastric slowing. And then quickly it was like, well, we're canceling cases, or, oh, we need clearance now. And everybody seems in flux about what to do. So that's really helpful. And I might even just add on one quick question after we flip from Danette, which is, when we've held these GLP-1 agonists for a period of time, I have just sort of individualized starting the same dose that was tolerated before or weaning back up based on how long. I don't know if you have any other guidance. I've just been individualizing how I approach it.
Yeah, we see this a lot with, the supply shortages as well. And so I kind of go by how the patient's experience was with titrating up. If they're really easy and quick, and especially if they only missed 1 or 2 doses, then I'll just restart it at the previous dose. Otherwise, I will do maybe a more rapid up titration.
Perfect. Yeah. Okay, good. Just making sure I'm in concert with endocrinology. So, and then for Danette, this was a really good presentation. There was so much information that when Andy asked, where might you have had residual questions? This was one I was like, maybe it's worth just revisiting those salient points of what are the basics of hormone replacement, where we went from give it to everybody years ago to give it to nobody to give it to some people now, and just maybe re-emphasizing some of those salient points about how are we generally replacing? Is that PCP's role? Is that gynecology's role? Is that endocrine's role? Is it a combination? If you have any thoughts about that, those are the 2 points I'm like, oh, I'd like to even expand more on.
Yeah. So I would say if mostly is prescribed by someone's OBGYN, but there are, a lot of women who go to their primary care provider, or internal medicine provider. So not as much for endocrinology, but what we have found in the literature is more your OBGYNs are going to be more likely to prescribe compared to PCPs, family medicine, internal medicine, and it's more like, well, okay, if you're an OBGYN, you're going to be focusing on that more than if you're in other disciplines. It's, at least that's an assumption. And to give more education about hormone replacement therapy, because as you said, first of us, it's changed over the years, whether it's safe or not safe, who should have it, who shouldn't have it. And so now the thought is, you can even prescribe it to someone who's over 60 as long as the benefits outweigh the risk, and they do not have, a lot of medical conditions that would, such as, risk for cancer or whatnot. So I think, maybe expanding on it would be good because things keep changing as we learn more. But, they have, found where hormone replacement therapy can actually reduce cardiovascular risk, metabolic syndrome. So, maybe, like the next time we do the presentation, I can maybe replace a few slides with some other slides and just kind of swap out or something, because the World Health, I'm sorry, there were some bunch of studies that came out, I think it was like in early 2000s that focused on one particular study and said, oh gosh, if you take hormone replacement therapy, you're going to end up with cancer. And so then a lot of women, it really significantly declined, but it was based off of one study, that wasn't well controlled. And so now they're trying to basically make up for all that and say, hey, wait a minute, we need to educate consumers, providers, and clarify, what are the benefits of hormone replacement therapy. So I hope that helped to answer some of those questions.
It sure does. And honestly, Goutham, I kind of bring up these 2 points because like smoking cessation is not really controversial, right? But these 2 things seem like they're still in flux.
Yeah.
And
So I can update some things. So I'm on the US Preventive Services Task Force, and we spend a lot of time on this. So the recommendation is actually quite clear. Do not use HRT for cardiovascular prevention or osteoporosis. And I just sent out a link. It can be used for symptom relief, generally speaking. And I don't know, Austin, I think I'm several years ahead of you, but there was a time, early 2000s or so, where we were calling individual patients to get them off of HRT because of the increased risk of thrombosis and the increased cardiovascular risk. That was a big pain. But to initiate it now in 2023, 2024, for that purpose is not recommended by anybody. So I think, Danette, I agree. I think we should probably look at this as a whole issue at some point within this, because there's not too many people who think, oh my gosh, I'm preventing heart disease with HRT, but I think the role of HRT, specifically how you prescribe it and for what duration and for what types of symptoms, would be really important.
Yeah, there's so much controversial literature, even with osteoporosis, like what type of hormone therapy do you give them? Do you give them, HRT? Do you give them SERMs? What do you prescribe? Because there is some research out there, a lot of it about osteoporosis. So I think it'd be great to get together and pull that information together, especially the controversial literature.
Okay. All right. Thank you. Before we go on to our cases, are there any additional outstanding questions or comments? And then I'm going to editorialize for a little bit. So, I want to thank everyone for presenting their cases, and I want to give you some of my experience. So I've been doing echo now for 12, 13 years, and mostly at the University of Chicago, but for at least 4 or 5 years here in Ohio as well. And a lot of the cases get to the same point. I don't understand what to do. This patient has obesity. He smokes 2 packs a day. His diabetes is out of control. We're prescribed a CGM, but he doesn't want to use it. We increased his insulin, but he has trouble getting it. And there's a couple of things I would say. One is strategies, because this applies. The echo I did at Chicago was children, but a couple of things. First of all, you don't want that to affect you as a provider, and all of you are highly motivated, and you provided incredible amounts of help to the people that I can see, and that you should be applauded for that. But that's not everyone. You're enrolled in this program, and so I think one of the things you can do is to lower your expectations to the point where the patient returned for follow-up in a reasonable time frame. Congratulations, kudos to you. You know, I cut back from 2 packs. The guy I saw yesterday cut back from 2 packs of cigarettes today to 1.5. He's only done this for 3 days. I said, well, that's something, right? You know, that's some progress. So even a little bit of progress is something. Remember, in primary care, and we say this in family medicine, but I think it applies to internal medicine, pediatrics, OB-GYN as well. Our duty is to have a positive influence on people's health, not to solve every single problem, right, that comes through. And if you keep that in mind, I think that will help you a great deal. The other thing I often get asked is, you know, and this is probably, I mean, I think children and adolescents can be a lot more frustrating because they may not be engaged and the family may not be engaged. And you can say something to your patients to the effect of, you know, I've been working very hard with you for the last 6 months, and I'm not seeing a lot of progress here. And I just want to ask you a few questions. Is this of interest to you? Do you find my help valuable? And if the answer is equivocal, you can even offer something like, maybe you're not quite ready to make some of the changes that, you know, that we've discussed here. Perhaps let's take a break for a while, and you come back and let me know when you're ready to make changes. And when I have tried that approach, quite often people will come back a couple of months later and say, gosh, because they have this fear that, you know, we are invested in them to a certain degree, and that you are starting to pull away, because we only have a finite number of people that we can invest in, of course. So we have finite resources. So they'll say, well, wait a second, maybe I should be more motivated because this person is sincere and is trying to help me. The other thing I will talk to you about is, and I sent out this article because I was reading it last night because I had clinic yesterday and I was just as frustrated as many of you are. All my patients are older. All of them have obesity, and just about all of them have type 2 diabetes. Well, and yesterday was not a day where I saw a lot of kids, and a lot of them were really frustrating. And I started to wonder, what is it? Why is this guy only taking his diabetes medications once in a while? And I looked through the conventional reasons online, and they were like, well, cost of medication, difficulty accessing the pharmacy, fear of side effects, lack of trust in the medication, which makes no sense. Why would you take it one day and then not trust it the next, right? So then I started like, this is not right. He has no lack of access. He lives near the pharmacy. You know, he's got coverage. What is going on? And ultimately, it was conscientiousness overall. So this guy shows up late. He shows up to work late. He shows up to the dentist late. He picks up his kids late. He doesn't go to pick up his prescriptions on time. This is a characteristic of him. And if you are up against that, you're going to get very, very frustrated, because there's no way that we can change that. We can help him to set reminders and help him to be motivated. So keep that in mind, that sometimes in those patients, those small victories are really important. I urge you to read this over, because it's not just health-related behavior. And I always wondered, you know, I watched this show a while ago, and I know I've said this in Echo before. It was a training program for some of you know, in Cleveland, we have a restaurant that employs ex-convicts, right? Nonviolent ex-offenders. And the guy is absolutely wonderful, and he's made a big difference. This one was for women, and they could train in different occupations. One of them was pastry chef. And then this lady was, you know, doing her best, and her job was to put icing swirls on top of these little cupcakes so they could be sold in the pastry shop. And she had about 36 of these to do, and all of them were lopsided. And the owner said, I can't sell these. These are lopsided. And her response was, yeah, but look at this one over here. It's perfect. And she was happy with that. And I thought, Well, that's an interesting way of looking at it. So sometimes our patients might have that perspective as well. Yeah, I didn't take my insulin last night, but I was okay over the weekend. I was pretty good. So I think if you read more about how our patients think, it'll help you to manage it. Because the worst thing is for you to give up and to get frustrated and angry, which I see in our residents all the time, is I don't understand what's so hard about getting this. Well, it can be difficult for some people. Thank you, everybody. Back to Andy just for a couple of moments.
Okay, so just as a final reminder, you can access all past and present echo recordings on our website. The cardio spring webinar is coming up on February 28th, and you can register at the cardio website there. Another reminder that our spring 2024 echo series will be a updated repeat of the current health equity and cardiovascular risk echo series. We would love to see you all there. We are adding a disability didactic as well, based on comments. And then just some final closeout reminders. A post-clinic survey will be emailed to you. Please complete that by 5 o'clock tomorrow. You'll also see a clinic exit survey, just an overview of the entire series. We would love your feedback, especially since we're repeating the topic in the spring. And then just let me know if you have any questions. And otherwise, thank you.
All right. Thank you, Andy. Thank you, everyone, for participating in the series over the last 12 weeks. It's a major commitment. I really appreciate it. And have a wonderful holiday season. And hopefully we'll see you in the new year sometime. Take care. Bye-bye.